It's my pleasure to introduce our speaker for today, Dr. Noel Merz. Dr. Merz received her bachelor's degree from the University of Chicago, her medical degree from Harvard. She then had her residency at UCSF and then fellowship at Cedars-Sinai, where she is now professor of medicine. She's also the Irwin and Sheila Allen Chair in Women's Health Research, the director of the Barbra Streisand Women's Health Center, the director of the Preventative Cardiac Center, director of the Linda Joy Pollan Women's Heart Health Program. She has a lot of directing, and also the Erica Glazer Women's Heart Research Initiative. She's also a fellow of the American Heart Association, the American College of Cardiology, and the European Society of Cardiology. Her research interests include women and heart disease. Obviously, that's why we have her here today. Also mental stress and how that impacts heart disease, the role of exercise and stress management, and the role of nutrition. She has and always, she is now and has always been well funded by the NIH. She's currently chair of the NIH-sponsored Women's Ischemic Syndrome Evaluation, or WISE initiative. She has published over 250 manuscripts that have been cited over 75,000 times, and an H-index of 98. And she's also done great at putting her research out into the general community. She has a TED Talk and is always quoted in magazines and newspapers and on news shows. So we are very honored to get you here. This was a rescheduled one, so we got you actually twice in 2 weeks. So we really appreciate your time. Look forward to your talk.
Well, thank you. What a lovely introduction, Dr. Lindsay. It's also a pleasure to see my colleague, Dr. Mavis Jarvis. We recently had a high impact factor article in the Lancet, and I was delighted to serve on that panel. I was asked to talk about sex differences in the cardiovascular system, and I realize in modifying this title, I missed a word. So what I'm going to share with you is an example of sex as a biological variable, SABV, which is now policy at our National Institutes of Health. So for those of you that would like to get or retain your NIH grants, this is something that you want to pay attention to. And then I will show you as an example, because I'm a cardiologist, how it works in heart. These are my disclosures, and they are not related to this topic, but of course we always disclose. So let's start with some terms, sex and gender differences, and again, heart disease. Sex, of course, is the biological sexual differentiation. So specifically, women have ovaries and men have testes. Gender is now commonly accepted as the sociocultural attributes that are often assigned to that sex. And here's an example. These are all evidence-based. Citations are in the lower right-hand corner. Women typically have complex social networks. Men often rely on their wives for their sociocultural attributes. More terminology. Sex genotype is XX for women. These are the sex genes. They're not all genes, but these are the ones that determine sex. And so XX dictates ovarian development of those stromal cells in utero. Sex phenotype, however, is the genotype expression given to certain conditions. So specifically, premenopausal women have higher estrogen levels than postmenopausal women, and that's due to their ovulation. They're making estrogen. The postmenopausal women have lower estrogen levels due to no ovulation. Both are XX genotype, but they differ in phenotypic expression. And of course, these things can impact what we do as healthcare providers and as investigators. So here are some examples. Sex differences in perception. So women have greater perception, high frequency, non-auditory brain testing. Gay men are intermediate between women. This is high frequency MRI testing, fairly objective. And this suggests that this might be genotypic. And this is one of, 20 years ago data where the LGBTQ community was saying, hey, this is the way we are. Don't bother us. Let us do our thing. Let us be normal people. This is who we are. Sex differences in pain. Women have lower thermal pain thresholds compared to men. Again, evidence-based, using standardized pain testing. Thresholds appear to be mediated by estrogen levels. So higher estrogen levels in younger women is associated with a greater perception or enhanced pain. And this is suggesting that it may be phenotypic. For those of you that are interested in pain or anesthesia, if you go to the average pain clinic, it's filled with premenopausal women. And there aren't that many postmenopausal women and very few men. Sex and gender differences in heart disease. Well, here, let's switch to gender. Again, remember socio-cultural differences. Women are more comfortable discussing feelings with friends and reporting symptoms to physicians. And this is possibly due to gender-related acculturation. Historically, not so much true anymore. Women's jobs were to become pregnant, to take care of babies and children and elders. And thus they spent a lot of time looking at and taking care of bodies. And maybe that's an acculturated tribute that you feel more comfortable talking about it. Gender differences in physician response. This has been in the New England Journal probably every 10 years for the last 30 years. Physicians are more likely to evaluate men with symptoms of cardiovascular disease. And this is possibly due to gender-related presentation styles. It's possibly related to cultural sexism or racism bias. And the more that we talk about critical race theory, the more that we see that it really is everywhere. No one is immune from this if you live in society. So, and it's not excusing it, it's just that we should identify it and take steps to rectify it. So what would be the consequences? And again, we're using the example of heart disease. Well, if you have a sex difference in pain perception, if women perceive their chest pain sooner after the onset of ischemia or MI, which stands for myocardial infarction, heart attack, this will lead to a longer estimated ischemia onset time in the emergency department, potentially leading to the conclusion that, quote, women delay seeking treatment, which is all over the literature. It's like, why didn't you come in? Why didn't you come in sooner? Why did you come in 10 minutes later than the man? And this is also makes more women ineligible for the life-saving thrombolytic clot-busting therapies, going up to the cath lab or getting streptokinase. And both of these would lead to more adverse outcomes, which is all over the literature. What about gender differences? Well, if women report generally more symptoms suggestive of chest pain, this will be a less effective diagnostic tool. If the gal comes in and tells you about toe itch, hair pain, chest pain, and belly pain, the doc gets confused. We all get confused. So this could lead to a physician lack of confidence in the testing and may also suggest that chest pain symptoms may be difficult to optimize as a tool for that. So these are, hypotheses. Let's go forward. So here's a diagram from this paper, most recently in the Lancet. And it really tells you about the interrelationship between sex and gender in health, disease, and medicine. So this concept is not sort of a hypothesis anymore. This is pretty real. And as I shared with you, we already have a lot of evidence about sex and gender differences. So now we have to figure out what are we going to do about it. So I'm going to walk you through things that we've been doing in our center. We have an endowed center for women's heart disease, endowed by Barbra Streisand by fundraising. She didn't just pay for it. She was a real advocate for us. So we'll talk about our preamble, the 1980s science through the 90s and early aughts policy, and then we'll talk about going forward. So why did Barbra Streisand hear this call? These are two women. On the left, you probably may not know, depending on your age, that's Dr. Bernadine Healy, and she was our first female director of the National Institutes of Health. And she, in the 1990s, responded to some demographic publications about this epidemic of death in women. Women were dying of heart disease, where prior to that, they didn't seem to get heart disease. Barbra on the right, Barbra Streisand, and this was, she, won multiple Academy Awards for not only producing and starring and singing in The Yentl, which again is a movie, depending on your age, but it is a movie about a young woman in Eastern Europe, turn of the century. Her goal was she wanted to become literate. She wanted to be able to read and write. And in that society, you had to be a man to be able to study. And so she impersonated a man. This is, again, the story of the movie. So Bernadine Healy wrote in the New England Journal that she thought this epidemic of death that we were seeing in women due to cardiovascular disease was potentially due to the Yentl syndrome, meaning if you didn't look like a man, you didn't have the same rights and privileges that men had. And so shifted into medical terms, if you didn't present in the male pattern that the physicians were all taught looked like heart disease, you'd just be missed. So these were the data at that time. Women in the red bars became the new majority of cardiovascular disease deaths. This is unheard of, never had been observed. The Yentl movie and the New England Journal Yentl syndrome came out in the 1990s. The Women's Ischemia Syndrome Evaluation, which I have had the honor to chair for almost 30 years now, sponsored by National Heart, Lung, and Blood and the American Heart Association, both had Heart Truth and Red Dress campaigns. We sort of make the joke, it took 12 years to take action. Probably if it had been about the prostate, it would have been a little faster, because again, this is our federal government, but that's a minor joke and you can decide if you're laughing or not. Okay, so what happened next? Science. This is a cartoon to explain that that minor joke is kind of true, that so much of our apparatus, including science, was really focused on men. And one of the things that we say is for men and by men, because the scientists were all men. So this is the cartoon. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anyone. The Y study was commissioned. We've made a number of observations. I'm just going to give you a whirlwind because every day was like Christmas, because women had been so not studied. Everything that you saw was reportable. So here's one of the examples, and this was working together with Dr. Renu Vermani and Alan Burke at our Bethesda National Institutes of Health Pathology at the time in the late 90s. And we demonstrated that heart attack victims, so all of these are pathology samples. These were people that died of a heart attack, often sudden cardiac death. And demonstrating that the women most often, especially the younger women, were eroding their plaque. This is a cross-section of their coronary artery, and they were distally embolizing, small little tiny emboli, where men were much more likely to have these big fatty plaques. They ruptured and they caused this big bad clot in one of the larger arteries. And just again, to sort of make it palatable in lay terms, women erode and men explode. But the deal is they both died. So this is lethal. And even though the pattern is different, it's still really bad. Another thing that we did, which was very innovative at the time, now pretty commonplace, is we did intravascular ultrasound. So much of what we grew up with in cardiology was doing what we call luminograms. We shoot dye down the coronary artery, symbolized here by the red color. And because of a negative contrast, you can sort of see that the artery is plugged up. What we typically didn't do and was innovative at that time was with intravascular ultrasound, we started seeing the fatty plaque because we were looking at the artery wall, not just a luminogram. And I think anybody could tell us in panel A, which is a male pattern, where the obstruction is, where the problem is. So if a cardiologist was going to throw in a stent or a surgeon was going to bypass that artery, it's pretty obvious what should happen. This is a plumbing problem. Women pattern, on the other hand, and again, this was what we described, women hadn't been studied before, had a much different pattern of fat deposition. They had more what we call negative remodeling. So the artery was just getting smaller and smaller, even though there wasn't any particular area that was plugged up. So there really there's no plumbing solution. But the ischemia, which causes a heart attack, is the same. Again, the consequences are bad. Again, to the more lay public, where do men put their fat when they become overweight or obese? Visceral, right? They often look pregnant, very, very overweight men, skinny ankles, don't have a lot of other fat. How do women when they become overweight or obese? That subcutaneous cellulite, typically in the buttocks and the thighs. So women and men lay down fat differently in the coronary arteries as well. And this will have consequences for diagnostic testing and missing if you don't know what to look for. So we put kind of a lot of this WISE work together. We were inspired to see that other people were also starting to look at sex differences. And we published this editorial in response to several large papers that when women look like men, and about a third to 40% of women, when they present, they do look like men. They look like a male pattern. I'm not saying they physically look like men, but their pattern of disease is easily recognizable. It looks like probably up to 50 or 60% of women present with what we call small vessel dysfunction, as I showed in that prior study. And what you can see then is when you look like a man, the doc knows what to do. And they prescribe these 4 magic pills that if you have a recognized heart problem and you're on those 4 pills a year later, you have an over 90% chance of being alive. You can see that there's relatively fewer people in this bucket, but they're mostly women. And then what you can also see is that less treatment is delivered because the pattern is not recognized. They're often told that there really doesn't seem to be a problem. And it is a surplus of death. If you add this up, these are the female surplus of death. Okay, so we went then and said, gosh, we better do something about this. And certainly as investigators, we publish, we network, we go to scientific sessions, we kind of preach to the choir. And at the end of the day, if you don't see the needle moving, then you say, well, maybe we should do something about policy. And again, you know, the kinds of things that we publish then in with larger consortiums, and when we start talking with public health people as well as our legislators, that is a way to make change. So I wanted, what happened to my policy? Yeah, here's policy. So one of the things that we've done increasingly in cardiovascular disease, because we do have a lot of evidence, is we have class 1 guidelines. And class 1 says, you got to do this. This is safe, it's effective, it's beneficial. And so we have over the years shaped guidelines to be that when they differ for men and women, when there's an important enough sex difference, then it's in the guidelines. So women, for example, with acute coronary syndromes are much more likely to have elevated heart failure biomarkers. And that dictates treatment that would be different from the men who have more elevated damage markers, just as an example. These guidelines then become some of our quality metrics. And physicians, of course, are always interested in quality. Hospitals get rated on quality. And hospitals care about this actually quite a lot. So here's an example. This is not our work. Lovely to see other people doing it. Before and after the acute coronary syndrome guidelines came out that you needed to be put on those 4 magic pills unless you had a strong contraindication. And it's a little hard, I color coded it just to understand the figure. So following guideline implementation, mortality for women improves. Now you'll see that mortality for men did not change. Probably they were already getting guidelines. And then here's what's left in the blue: persistent sex gap, meaning women are still not doing as well as men. And this suggests that more work is needed in sex-specific pathophysiology, meaning you've got the traditional stuff covered with the 4 magic pills. What's left? And are there things that are different about women where the treatment would need to be different, or the approach for diagnostics? While we were working on all this, here's what happened. The curve bent, and again, this is observational, this is epidemiology. We did see a 43% reduction in female mortality. Men continued to decline. The red arrows are those awareness and policy and guideline campaigns. So, you know, the issue, of course, with epidemiology and observational is it's just hypothesis generating. We can't say true, related. But it was certainly gratifying to see that things were changing. The needle was moving. We continue, however, to struggle with relatively low rates of awareness. We do better, and then we get kind of stuck. And we continue up into a more recent survey in 2019, where we've dipped below 50% again. Most women still will tell you that breast cancer is their leading healthcare threat, which is completely not true. We've done a really good job with breast cancer because they're so aware of it. Here's also, we have residual problematic issues about including women in clinical trials. So this was done by our good Office of Women's Health in the FDA and published 3 years ago in JACC. And it basically demonstrates that the big ticket items, which are acute coronary syndrome, those are threatened heart attacks and include heart attacks, coronary artery syndrome, unstable angina, and heart failure, continue to under-enroll women to almost half. So pulmonary hypertension is a sex-linked disorder. It's mostly as women, so thank goodness they recruited women. And then atrial fibrillation is a pretty mixed bag, but an increased epidemic. And a lot of these studies are more recent, and there is more pressure to include women in clinical trials. So just like you're having this education today, and you will be more smartened up about it when you are in the process of planning clinical trials and you get into those leadership circles, you hopefully will do this as well. I know that we've got some basic scientists here. There is underreporting of the sex of animals in basic science studies. And these are, you know, the foundation of what we do to develop things that improve human health. So if we start right out of the block and don't report and study both male and female animals, we're biased in the beginning. And the majority of drugs that are withdrawn after FDA approval are withdrawn because of unanticipated adverse side effects in women, and sometimes lethal. And that's why the drugs are withdrawn. So again, gotta study males and females. We are working with medical editors to require that the publication stratify the data by sex. If that's not relevant to the publication, they can put it in a supplement. Everything is uploaded now in online clouds. There's just no reason. And this way people can do their meta-analyses. They can look for these things. So again, we're got a lot of hard-headed editors out there, but we think we're making some progress. So going forward, what would I charge you with? What, if you had the opportunity, what should we be doing? We're real big on science advocacy. So as was mentioned in the introduction, I'll talk to anybody. I'll talk to religious leaders. I'll talk to, the ladies golf club. But I like to do TED Talks. I like to talk to CBS and NBC and NPR. And I would encourage you to do the same because these are critically important things. We have a lot of talk now about COVID. There are important sex differences in COVID. We're not talking about it. For example, early on, it looked like pregnant women were somewhat spared. That is so not true. And it's really hard to breathe when you're pregnant and to be intubated, and they can't roll you over because you're pregnant. They can't do your prone ventilation. So the public needs to know, and I hope you guys would as well. We're also real big on philanthropy. We're dealing now with a generation of women that actually control and have access to their own money. And that was not historically true. And philanthropy was often much, much more directed by men. And again, it's not they're not bad men. They just were more interested in the prostate than things that were actually killing a lot of people. So we're big on that. We work a lot on shaping clinical investigation that will formulate not only high impact research and publications, but will feed into our guidelines. And as we mentioned, we talk a lot about guidelines make good doctors great doctors, because it's right there either in the electronic health record, or if you don't have that yet, it's right there on the discharge sheets. Doctor, did you remember to prescribe the 4 magic pills? That's not how they're called, but and the hospitals like guidelines too, because they make good hospitals great hospitals. When a hospital can, show that their stenting mortality rate is extremely low, that their bypass rate is extremely low, that their discharge with heart failure and a heart attack and pneumonia is consistent with all of the guidelines, and the rehospitalization rates are low. This is what we need to be doing. This is how we optimize human health, and the hospitals are happy to market and say, this is a great hospital. Look at our quality outcomes. And then we talk a lot about education. We are working, we have a organization that works now with the AAMC to get sex and gender questions into the medical boards. And as you know, all medical students and trainees have to pass part 1, 2, and 3 of the boards to be licensed. You can get the MD, but you can't prescribe. You can't work as an MD if you don't pass those boards. And as we all know, in our student days, teachers teach to the test because they want you to pass the test. And presumably those questions are on the test because they're relevant. And then we also are working on specialty, so pediatrics, internal medicine, cardiology, Uro-GYN, you name it, general surgery, that all of this needs to be in the curriculum where it's relevant. It needs to be relevant. Focusing on disparities, be they related to racial, ethnic, non-Caucasian groups that are no longer minorities, whether they're related to socioeconomic status. We have now a good recognition of big gaps in rural versus metropolitan health and the social determinants of health. And these are relevant and can all be kind of bundled. There's a lot of intersectionality, but this is the time. There's recognition of this, and we are working hard to sort of figure out how and what to do. Last but not least, and you saw deployment of this in the pandemic, and our Zoom right now is a good example of that, the use of technology to deliver care. to do better diagnostics, which we can do remotely, to do better therapeutics, which we can also do remotely, and to do follow-ups, which we did a tremendous amount. We shifted to telemedicine very quickly. As a specialty physician, I see second and third opinions often from all over the United States, sometimes international. And they always say, well, can I do a telemedicine follow-up? And I would say, no, we can't, we're not allowed to do that. We can't go across state lines. You know, it has to do with regulation. It has to do with bills. And literally within 2 weeks, we were able to do it during the pandemic. So the informatic people and the billing people, and thankfully CMS and our insurance companies said, yeah, you know, care deferred is disaster care, right? And we were being overrun with COVID patients. So of course you wanted to try to keep as many people away from the medical center as possible. And it's not the same as in-person care, but gosh, it was a whole lot better than no care. So I wanted to leave plenty of time. Some of the stuff that I say is kind of controversial. I'm happy to be controversial. I hope I was provocative in your thinking. And this is our benefactor when she did the initial endowment. So I'm happy to take questions.
Okay, thank you for that talk. If you would like to ask a question, you can put your name in the chat and I can call on you, or we can just go ahead and someone can start out verbally if they're ready. I guess I can start out with the question. So you talked about the 4 pills, magic pills. I know you joked about them. Is this considered standard of care for women as well, or have they kind of looked at whether there might be a different combination?
Yeah, it turns out that many of the therapeutics that we use, so the low dose aspirin, and Azor and ARB, which is a blood pressure heart failure drug, the beta blockers, and the statin cholesterol medication, those are the 4 magic pills. They work equally well, meaning they reduce outcomes in women and men. They are slightly different, which is to say the low dose aspirin preferentially reduces stroke in women, but women have more strokes than men, so that sort of makes sense. The low dose aspirin preferentially reduces heart attacks in men. Those are both lumped together in our cardiovascular disease bucket, and they're kind of equally morbid, right? I mean, you know, a stroke or a heart attack, they're both kind of bad. You know, so there are differences, but the good news is in that armamentarium, they appear to be equally effective in women and men. I can read the chat. Do you want me to?
Sure. Yeah.
So here's the question in regards to differences in heart attacks between women and men. Are eroded plaques only found in women, or are they just more common in women? So yes, that's an excellent question. So we had a 2x2 table in that publication. And again, this is recorded, so you should be able to go back and find the publication. We had younger women and men, and then we had older women and men. And this plaque erosion was most common. So your first question is, you know, is it common? It was most common in younger women. It was more prevalent in women overall compared to men, but it wasn't exclusive to women. So when you think about a lot of things in biology, if you bother to look at it, male and female the distributions are quite overlapping, but the means are often different enough. And what you would care about and what we care about is it different enough to change your therapy or change your diagnostics? And these erosions were different enough. And it was one of the pieces of information that led us to really focus on non-obstructed plaque in the coronaries, saying, hey, you know, just because men don't suffer from it that much, like it's uncommon, so you don't see it that much, you don't really work on it, it's not a big problem. It was a big problem in women. So we have a whole line of evidence now related to 2 terms, and then I'll stop talking, MINOCA, MI with no obstructive coronary disease, and INOCA, ischemia with no obstructive coronary disease. And it's, it's just, it was ignored. Nobody thought much about it. And now it's pretty mainstream. Lots of research increasingly being translated into clinical care. Okay. The second one is in NOLA, especially in Black women, they are seen younger, linked perhaps to obesity and diabetes. So NOLA, Keith, you mean no obstructive coronaries?
No, he means
New
New
Orleans,
Orleans,
Louisiana.
Say it again, sorry.
In New Orleans, Louisiana, they call it NOLA.
Oh, I see.
And the hospitalized patients at Tulane,
Yeah,
they tended to be younger. They actually had more women than men, and they tended to have more obesity and diabetes. And I was wondering if you saw that in LA also.
California on average is a leaner state than a lot of other states. We don't know if it's our sunshine or, we have abundant fruits and vegetables. I mean, California cuisine, and you can be outside, people are probably more physically active. That said, Keith, you and I know that the average heart disease patient on average is overweight and unfit, right? And we are seeing more and more young diabesity. I think Tulane was a Virgo site. We were a Virgo site. Virgo stood for a study of young, under the age of 50, women and men that were having heart attacks, and just what did they look like? And the women were much sicker. They were more often diabetic, and they had more renal dysfunction, even though they were under 50. So I think probably that's true as a theme, but probably not to the extreme that you see in New Orleans. Yeah. Okay, from Marlene, could you exemplify clinical differences between sex phenotypes pre-post menopausal women that are currently being overlooked? Well, cardiovascular disease, right? Because I'm a cardiologist. I need to frame that. Yeah, our younger women often have a higher risk factor burden than the relatively older women. And remember, age is a big predictor of cardiovascular disease, probably because it represents area under the curve of exposure to those risk factors. And so for these premenopausal women to present with cardiovascular disease, and again, premenopause is under the age of 55, they often have a greater traditional risk factor load. So they're early onset hypertension with or without obesity, early onset diabetes with or without obesity. Those would be traditional risk factors, where our older women, they might have a little dyslipidemia, they're mildly hypertensive, they're just kind of old, and they flip into atrial fibrillation. Another thing that is coming along that is unique to women are things that are related to pregnancy. And there's a term for it now, adverse pregnancy outcomes. And so women that develop gestational hypertension, gestational diabetes, they are clearly at greater risk for early onset cardiovascular disease, often within 5 to 10 years. So if they're childbearing in their 20s, 30s, they are hypertensive and having problems in their 40s, 50s, instead of the mean age for women to get into trouble with cardiovascular diseases, 60s and 70s. There is also, with the menopausal women, of course, the whole hormone controversy. And it's very clear from the data that hormones do not protect, they do not prevent cardiovascular disease, menopausal hormone therapy. And they do appear to, when they are initiated in a fully postmenopausal woman, they can trigger heart attacks, probably because of plaque disruption. And then they also cumulatively are associated with increased dementia, probably from microemboli. You have to remember the estrogen hormones, typically delivered orally, are very prothrombotic. And we kind of have to keep learning that lesson over and over and over again. If I didn't address the phenotype that you were interested in, just speak up and we can go back. Okay, can you clarify, this from Megan, can you clarify women perceiving ischemia sooner actually leads to a delay of ER treatment? So, so if the woman comes in and says, oh, it's been intermittent, since yesterday afternoon, and the man comes in and says, I felt fine, and it just started. I have this elephant on my chest. Guess who gets the MI room? And again, it's not, these are not good doctors, bad doctors. This is not charge nurses that are, irresponsible or not paying attention. But the combination of women having a higher somatic awareness, which is, code for increased pain threshold, lower pain threshold, I should say. They feel it sooner. And then again, remember with the erosion, often the stuttering acute coronary syndrome, a little clot goes downstream, they have a little worse chest pain, they feel bad, but then it kind of clears. This kind of pattern, as well as the gendered issue of not taking, there is a gendered issue that it started with Freud, that women are more hysterical. Women can't be relied on. They're not good historians. They tell you about everything. It's like, and again, I don't, it's not good doctor, bad doctor. You've seen some of the reports. We've had two probably in the last 4 years that female physicians, one was female internists compared to male internists, this was in JAMA, their patients had 30-day mortality and health outcomes better by having an attending physician that was female. And it's observational, so again, true related, who knows? And then one out of Florida, where if the emergency room physician was female, the heart attack, their female heart attack victims had a lower mortality. And then they were able to do a little bit more of a deep dive, and they demonstrated in a network analysis that the male emergency room physicians who worked with at least 2 female colleagues, they also did better. And, the hypothesis is that you're in the break room and you're like, God, I saw another woman with chest pain. Can you believe these women? Oh, Dr. X, don't you know that heart disease is the leading killer of women? Let's go see her. I don't know. So I think these are all good. Hope I answered that question.
Yes, thank you.
So I have a question. In my lab, we look at arterial stiffness and sex differences there. And some data really suggests that females, we're talking about mice here, might be more protected in terms of hypertension, but be more susceptible for arterial stiffness. And I know you have a couple of clinical papers, but where kind of are we in terms of using pulse wave velocity or something similar like that to actually influence clinical care?
Yeah, we do pulse wave velocity, and we used to do the BART for peripheral endothelial function. Now we use the RHI from the fingertip. And I think the problem with these non-invasives is they're not sufficiently consistent to be diagnostic, right? At least not to my eye. And so they just don't cut the mustard in any of these guideline groups. So I'm just trying to answer your second question, is when are we going to be able to use these? And I don't know if it's because of day-to-day variability. I would think in your lab, I know in my lab, we really standardize it. We test at the same time of day. We test in a fasting state. We have a temperature controlled room. But, there may just be too much biologic variability in them for them to sort of be a useful diagnostic test. That'd be my kind of guess why it hasn't met those criteria. That said, for population research, I think it's very helpful. You know, if you test enough people, you can get over that standard deviation and start to see things. And then for, you know, very standardized and you're doing mechanistic research, you know, we continue to sort of forget about the pathology of cardiovascular disease, right? It's atherosclerosis thrombosis. And so we have a pretty good handle on athero at this point, and partly because we have these great drugs, right? We've got the statins, and now we have the injectables, and we'll probably have the microRNA, the inclisiran pretty soon. We're pretty good with the thrombosis. At least we know that it's there, and starting as long ago as low dose aspirin for the platelets. And now we have all the super aspirins, and now we have the DOACs, the direct oral anticoagulants that are really superior to warfarin. And they're starting to show that even in kind of routine cardiovascular disease, they're likely going to play a role in low doses. So we are left with sclerosis, which we don't, I think, really understand very well. And you know, folks that work in hypertension, you know, why do we call it essential hypertension? Because we still don't really understand, you know, a lot of it. The good news is we have drugs that work. You know, pretty much any drug that lowers the blood pressure seems to work, as long as it doesn't have off-target problems. And so how much of it is, you know, stiffening, premature, early onset, how much of it is kind of high cardiac output, how much of it is old aging arteries, cross-linking the collagen. I applaud people that toil in that area, because we should have a better understanding. And as you pointed out, we have Dr. Susan Cheng joined our group, and she's had a couple of blockbuster papers demonstrating very important sex differences in blood pressure trajectories over a lifetime. It was only seen in these massive Merz data sets that she's so creative at doing. You know, you just sort of, you're like, wake up and smell the coffee. How come we've been measuring blood pressure for 100 years. Why didn't we know about these trajectories? But now we do. And I would welcome your thoughts.
Yeah, I mean, I don't know, you know, I think so much of what we try to do translate to clinical is sometimes missed because of other reasons, right? Because the measurement isn't as accurate, or it's more variation. So it's really good to hear about the clinical side of that. But, you know, I'm hoping that maybe we'll be able to detect more female disease earlier by thinking about new risk factors that maybe are only applicable to one gender.
Yeah. Yeah, I mean, I think, you know, the pregnancy thing is, at least as far as we know, like NASA keeps saying they're trying to develop a placenta so that the male astronauts, you know, when we blow up the world, the male astronauts will go up to the space station. And I think they've given up, because now we have female astronauts, right? They figured out that's not going to happen. So until men can become pregnant, those are unique to women and may offer some clues. And then, you know, the other thing is the autoimmune disease. I didn't mention that, but, you know, 9 out of 10 autoimmune disorders are in women. And men and women have quite different immune systems, innate and adaptive. And that's really playing out in some of these viral pandemics, Ebola, H1N1 plus COVID. And but the autoimmune is an important, you know, a clinician can pay attention to that. And in our early onset patients, women, They are more often, they have lupus, a few rheumatoid arthritis, some Sjogren's, some thyroiditis. So vascular inflammation is part of this bucket, and that is most often preferential women. There's another question. This is from Sai. I am a medical student and I'm currently on the wards. What would your recommendation be for noticing clinical patterns of heart disease in women in addition to diagnostic tests? So for women, and this is true for some men, small men, signs and symptoms of ischemic heart disease, which is the most common, right? That's the acute coronary syndrome. You need to sort of have a higher level of suspicion in women because the diagnostic tests that you have routinely at your hands are not as sensitive. Again, think of that smoldering, eroded plaque. She doesn't have the 3 millimeters of ST segment elevation that the man with the exploded plaque and an occluded coronary artery has, right? The ST segment elevation. Women are going to more likely have non-specific ST2 wave changes. That's not diagnostic usually. You do want to make sure that your lab is using high sensitivity TNI or TNT. We've done a lot of work with TNI, and there look like there should be sex-specific thresholds and for abnormality, and the thresholds for women should be lower. I mean, it makes perfect sense. Again, it's like, why, why do we have to go through this again? Women are smaller than men on average. And so when their heart muscle leaks damage, there's relatively less troponin in the bloodstream. So either sex-specific thresholds or body surface area. And this is an area of controversy. We talk with the biomarker folks. I sometimes call them the biomarker mafia. And right around the time that we were really pitching that there should be sex-specific thresholds because of the evidence that has accumulated for the high sensitivity troponins, the whole African-American GFR debate broke, and that how that may or may not be real, right? It may or may not actually be due to inherent differences between African-American and non-African American glomerular filtration rates, and that this may have contributed to disparities and an under-recognition of renal disease in African Americans. So there's not when you get, there's one controversy going on and you want to try to get somebody's attention. So I don't know where that's going. And then last but not least on the wards, you would want to be thinking about that women are more often going to have non-obstructive coronary disease. So a CT angiogram might be more valuable than a stress echo or a stress SPECT, for example. And Dr. Pam Douglas, a colleague of Dr. Ferdinand and mine, and a very excellent investigator in her PROMISE trial, demonstrated that the CTA probably worked a little bit better in women. And that's not to say I'm a physiologist. I love seeing exercise and showing that they're unfit and that we need to get them exercising more. But those are the kinds of things that might be helpful to you on the wards. And good luck. Thanks for asking. There was one more from M. Thank you for these critical updates. And you remember that I came to visit Tulane for your Birch Research Day, and I remember that very fondly. So thank you.
Well, thank you so much. And hopefully we can have you again in person sometime in the future.
Good. All right. Keep up your great work. All right.
All right. Thank you, everybody. Bye-bye.
Have a good one.
Thank you, Noel.
Share, of course.